Assalamu alaikum, my dear students of 6 years. I will give you a lecture today from the vascular specialty. First I will introduce myself. I am Dr. Ahmed Osmane, Assistant Professor of Vascular Surgery in Vascular Surgery Department, Alexandria University. First, I will give you the varicose veins and chronic venous insufficiency. Actually, this lecture is from my colleague, Professor Dr. Naguib Al-Askari, but for some circumstances, he cannot give it nowadays, and I will give him this lecture instead of him. Let's start. What is the anatomy of the lower limb? We have to start with the anatomy, because anatomy and pathology is the surgery. So we start to understand the venous system. We have to start with the anatomy of the venous system. The venous system is composed of superficial veins, deep veins, and communicating. The superficial veins are of the lower limbs, the long and short saphenous. Another name is great and lesser saphenous. A third name is the internal and external saphenous. The deep veins are starting as the blood flow is coming down upwards, so we have to start with the veins of the leg, then the thigh, then the groin and abdomen. So first, the deep veins are vena comitant to each artery, two vena comitants to the anterior tibial artery, two vena comitants to the posterior tibial artery, and two vena comitants to the peroneal artery. Then they will form the popliteal artery, an infragenicular part, retrogenicular part, supragenicular part. At the point of the adductor canal, it will enter the adductor canal and to be the superficial femoral vein. Then it will continue as common femoral vein, passing the inguinal ligament to exchange his name to external iliac vein, then common iliac, then inferior vena cava. This is the deep system. Communicating veins are veins which communicate a vein to another. So it might communicate a superficial to a superficial, or deep to a deep, or superficial to deep, or skin dark to deep. So any vena which communicate a vein to another is a communicating vein. So perforators are the communicating veins which perforate the deep fascia. So perforators are only from the superficial to the deep system, or from the skin dark to the deep system. Let's start with the superficial vein. Here we'll see the dorsal venous arch. From the medial aspect will ascend the long saphenous to pass anterior to the medial malleus, then ascending upwards till the medial condyle of the femur, passing behind the medial condyle of the femur, and ascending upwards and medially till reaching the saphenofemoral junction. Before it enters the femoral, it pierces the deep fascia to reach the deep vein, the deep femoral vein. At the cribriform fascia, then forms the saphenofemoral junction. As a superficial system, it lies superficial to the muscle and fascia, and they have own well-developed muscle coats, the vein itself. The long saphenous vein is the longest vein in the body, and the surface anatomy, not the anatomy, the surface, how to reach it from the skin. We can reach the lower end 1 centimeter anterior and front to the medial malleus, 1 centimeter above and in front of the medial malleus. You will find a groove, then this groove is running in it the long saphenous. Upwards at the knee level, you can find it a hand breadth or 4 fingers just behind the patella or the tibia bone, okay? And upwards in the thigh, it will, or in the groin, it will end at the anteromedial side of the femoral 3.5 centimeter or 1.5 inch below and lateral to the pubic tubercle. Before it enters the femoral vein at the saphenofemoral junction, it receives the following tributaries, either 3 or 4. Superficial with or without deep external pudendal vein, superficial circumflex iliac, and superficial inferior epigastric vein. The deep veins. They accompany the axial arteries, as I said before, run within the muscle deep to the muscle fascia. The perforator, which perforates the deep fascia, they are communicator perforating the deep fascia to reach from the great saphenous to the deep system, lesser saphenous to the deep system, or from the ducts from the skin to the deep system. An example are the saphenofemoral, the saphenopopliteal, and saphenofemoral junction, mid-thigh perforator or Hunterian, it is the above knee perforators, medial calf perforators, and medial malleus. The medial malleus just below and above and 10 centimeter above, they are the Cockett's perforator. Another one major is the below knee, which is the Boyd's perforators. The thigh perforator is connecting usually the long saphenous to the main trunk, as drawn like this. The dots, the above knee is called dots, and the below knee is Boyd's perforator. The Cockets are three Cockets. Cockets are mainly directing the blood from the skin to the deep system. Surgical anatomy of the lower limb veins. All the lower limb veins have valves to direct venous return in one direction, either from low upwards, anti-gravity, or from superficial to the deep. Why from superficial to the deep? Because the caliber of the superficial veins, saphenous, long saphenous, or short saphenous, is carrying 10% of the blood of venous return. However, the deep system carrying 90% of the venous return. So logically, the 10 draining in the 19. Then another reason is that superficial are lying in the subcutaneous, so they are soft. However, the deep system are supported heavily by the muscle, within the muscle, so it is stronger than the superficial, so it can carry the most of the venous return. This direction is maintained by valves. The competence venomuscular pump is composed of why the blood of the veins of venous return is directed upwards toward the heart. Why it is not anti-gravity? Why? It is guarded, superficial and deep veins are guarded by competent valves, maintaining the blood only in one direction. Then, again, a competent valve directing the blood from superficial to the deep system, and the powerful muscle, which what we call the muscle pump. Muscle pump are the tone of muscles at rest. So even at rest, the muscles are contracted to some extent and to maintain the venous return. By acting of the muscle, sure, the blood will empty rapidly and in a better way. So, chronic venous insufficiency, CVI. What is the definition? By definition, it is a collectively described the manifestations of impaired venous return due to abnormal venous system. So, this chronic venous insufficiency of the CVI is a pattern of multi-diseases which concerning the venous system. So, the superficial thrombophlebitis, even the simple, is one of the chronic venous insufficiency. The deep vein thrombosis is a chronic venous insufficiency. Primary varicose veins again. Secondary varicose veins, even لو any mean affecting the deep or superficial or communicating system, promoting or deliver a disease, it is called chronic venous insufficiency. The etiology or the microscopic etiology is the valve incompetence. It is impaired valve, and less commonly by venous obstruction. It is the secondary. So what is the pathophysiology? The main defect in the lower limb venous system may be in the superficial deep or perforating veins, and this problem is usually in the valve, which incompetence or reflux, but sometimes it is the form of obstruction or a combination, might be both. The defect may be a primary, I don't know why, What is the reason? So it is a primary. It might be related to the structural weakness, okay, which maintain the valve non-functioning valves. So there is a regurgitation. A secondary defect, for example, is due to known pathology affecting the system. For example, the deep vein thrombosis, which collectively giving the post-phlebitic syndrome. Whatever the cause of chronic venous insufficiency, it will eventually cause a venous hypertension. This is the pathology of the reflux. So we have the end results is venous hypertension, which will give us the microscopic changes and give us again in the other side the clinical manifestations. The severity of and symptoms of chronic venous insufficiency depending on the degree and prolonged or the duration of the venous hypertension. The best classification which showing the causes or the manifestation or grading of the chronic venous insufficiency is the CAP classification. CAP classification. C is for clinical classification, E for etiological, A for anatomical, and P for pathological classification. This diagram showing the how to an extent, okay, to summarize the C. C0, Z1, C2, 3, 4, 5, and 6. C0, there is no visible or palpable manifestation or any veins, they are normal. Class 1, what we say telangiectasia or spider veins. 2 are varicose veins. 3 is edema. 4, the pigmentation, lipodermatosclerosis or eczema. This is a clinical manifestation. Swelling, first start, edema, then followed by rupture of the red blood corpuscles, giving pigmentation, which is like a tattoo. It is not disappearing at all. And the inflammatory changes occurring within the subcutaneous, giving the lipodermatosclerosis, which enter the skin, scaly, with low perfused part of the skin, giving an eczema, and followed by ulcer or healed ulcer, stage 5, and last one is the active venous ulcer. It might be either asymptomatic with no manifestations, it might be presented just for disfigurement or just seeing the changes, or might be a symptomatic condition. What is the etiology? CAP, C, finished, E, etiology. Might be congenital or congenital, it is like the Klippel-Trenaunay syndrome. It might be, it is associated with arteriovenous minimal or microscopic arteriovenous malformations with making a venous hypertension and edema and secondary varicose veins of the limb. It might be a primary. I don't know why. In most of the patient, young age, having primary dilated varicose veins, and this theory is usually associated with the same theory of hernia and or with varicose veins, varicocele. It might be a secondary due to affection of the deep system, most commonly by thrombosis, deep vein thrombosis. So it is a post-thrombotic or post-phlebitic syndrome, the same is. The anatomical, either in the superficial, perforator, or deep vein. It is the anatomy as described before, or in no venous. The pathophysiological, why there is a disease. Either there is a reflux or obstruction, or both reflux and obstruction. So, what are the manifestations, clinical manifestations of chronic venous insufficiency? The early one are postural discomfort. That means when the patient is long standing, he is suffering from dull aching due to congestion of the veins, dull aching pain, okay, or discomfort, not so pain, but discomfort. When he is recumbent and supine, elevating his limb, so he is well. Then this manifestation is augmented by swelling, obvious swelling. What is the lower limb edema? The most dependent part of the leg is the lower third part of the leg. So it is the more suffering part of the manifestations of the chronic venous insufficiency. So we call this is the gaiter area. And due to perforatory, especially Cockett's perforatory, which is directly from the skin direct to the deep system, when these Cockett's are incompetence or reflux, so the high venous pressure, relatively high venous pressure is directed toward the skin, so affecting the skin by more this manifestation rapidly and severe, for example by ulceration. So the medial part of the gaiter area is called the ulcer bearing area. So for the lower limb edema, which is the first obvious manifestation in the chronic venous insufficiency, it starts usually below, in the retromalleolar space behind the medial malleus, because the patient is dependent. So the most affected part is the lower third, and the edema will start from the retromalleolar space behind the medial malleus. Muscle cramp. Muscle cramp is for exaggeration congestion, because the calf muscle at night, when the patient stretching his limb on sleeping, the muscle are contracting. Why they are contracting? Because they are congested deeply by the subsolear plexus of blood, which irritate the muscle to cramp. When the condition is persistent and for long duration, what will come next? This edema promote an inflammatory response, ended by lay down of fibrous tissue. Then the ankle will be a strong brown edema, not easily disappeared, and the red blood corpuscles will escape from the intravascular compartment to outside, then rupture, forming the brown pigmentation, brown to black pigmentation. This is staining of the hemosiderin pigment in the skin. This hemosiderin is irritating by itself, so making the eczema of the skin itchy. It is itchy. And this inflammatory changes with itchy, with all this fibrous tissue, render the lower third of the leg by thickened fibrosis, what we call hypodermatosclerosis. And in severe cases, the lower third is heavily fibrosed with normal leg, what we call inverted champagne bottle appearance. Then followed by venous ulcer. We cannot ignore the varicose veins, which might be obeying the long or short saphenous, what we call primary veins, or secondary, which are scattered. The venous ulcer by itself, it might have a infected floor or granulation floor, or even bleeding floor from congestion. And this bleeding will not stop except after elevation of the lower limb above the level of the heart. How to investigate a venous disease? We have two aims: to identify existence, site, and degree of venous reflux, and to confirm that the deep venous is patent and yes or no as competent. There is no reflux and there is no occlusion. So what are the tools? The gold standard is the Doppler ultrasound. Might be portable beside examination. It is accurate in detecting saphenofemoral reflux in the groin. So, 4 centimeter below and lateral to the pubic tubercle, we put our probe of the Doppler, then we confirm by squeezing. We heard first a minimal monophasic, what we call monophasic sound, like that. To confirm that this is the venous site, I am on exactly the femoral vein, I have to squeeze the muscles, either the thigh or the leg, what we call augmentation. I make the venous return more obvious, so the sound will augment, but still a biphasic, not very strong. So contrary, when I'm still on the saphenofemoral and ask the patient to strain or coughing, so if the saphenofemoral is competent, the flow will not be transmitted from the abdomen toward the site of the saphenofemoral on the femoral vein because of the competence of the saphenofemoral valve. But when it is incompetent, I will hear a sound, which sound is like the biphasic, like the augmentation. Okay, this augmentation is not in the direction of the blood, it is the contrary of the direction of blood. So this part is incompetent. The saphenofemoral junction is incompetent. The color duplex, it is a new modality, okay, which transforms not only the sound heard by the Doppler, but in addition, it will transform figures of the waves of the venous waves, and again, I will see by my eyes on the monitor the wall of the vein and the lumen and the blood flow within this lumen. It demonstrates the venous reflux into superficial and deep. It is easily to detect by it the superficial or deep system, and we can detect the degree even of reflux, what we call dynamic study by duplex ultrasound. And sure, the communicating or perforator, I can detect which is incompetent and mark this incompetent perforator on the skin to manage it surgically later on. The color duplex ultrasonography, the color is, it is the direction of the blood. I can give a red and blue color. The red one is not an artery, but it is in one direction. The other color, the blue, for example, it is the other direction of the blood. So I can judge or make the blue for the vein or the artery or whatever, but the color is a different direction, as shown like that. So what we can direct by the color duplex ultrasonography? The normal direction of the venous return by itself, for example, like that. However, with training, training meaning I transform the high abdominal pressure towards the lower limb. It should not be transformed to the lower limb, guarded by the saphenofemoral and deep system valves competence. So when these valves are incompetent, reflux will seen in the vein in the other direction. Instead to be blue, for example, it will be red. So there is a reflux in the other direction. However, when the superficial system is incompetent, but still the deep system is healthy, so I will see empty of the vein on straining of the deep system. It is empty because it will not allow reflux to be on straining. So it is still healthy. Another tool is the photoplethysmography. Actually, because of the cost, and it is giving the volume, difference in volume. So it is maintained for academic studies only. It is not usually used in clinical diagnosis. The venogram. Venogram should be limited to certain patients, which I have to study the deep system actually in the lower limb and in the pelvis and even in the abdomen. That means I have to study the superficial deep system of the lower limb, the iliac, and the inferior vena cava. And the patient with suspected post-phlebitic syndrome, that means chronic complications of maltreated deep vein thrombosis, the first choice is duplex ultrasound, the second is ascending venograph to show the extent of recanalization of the deep system after occlusion or still occluded or rendered by fibrous tissue streaks. All this will be diagnosed better by ascending venogram, like that. This is the anteroposterior view, and this is the lateral view. It is a normal venogram. Management of primary varicose veins. I don't know what is, but there is affection of the primary system, superficial, long saphenous or short saphenous. So according to the grades, the management will be in minor varicose veins, just support stocking. What is support? Support, that means advise the patient not to stand longly, okay, and take rest as much as he can, and at night, at bedtime, he has to raising his limb in a level higher than the heart. And again, the supporting stocking, elastic stocking while standing. So I am confident that he will elevate his limb at bedtime, but before standing, he will wear the elastic stocking to make his day lightly without congestion. Till the end of the day, he will remove the elastic stocking and raising his limb up again. The injection compression stereotherapy is maintained for many reasons. For example, cosmetic. There is disfigurement, their appearance is not good, so I have to inject stereotherapy to occlude this vein. But another case, it might be for injection the perforator, ultrasound guided to detect where is the perforator, and I see where is the perforator, and I directly direct sclerotherapy for this incompetent perforator. A third reason, it might be for a huge saccular vein and will impending rupture. So I will empty this and inject to avoid rupture of this saccule or varicose veins. Truncal or major varicose veins, long or short saphenous with incomes. What I can do? In addition, this support stocking and injection surgery are maintained, but I have first to detect where is the defect, okay? And am I need to strip to remove this vein? This vein is unhealthy and it will maintain or giving other manifestation, edema, ulcers, pigmentations, chronic venous insufficiency. It is a chronic disease. So I have to either remove or not. What is the judge? If the saphenofemoral or saphenopopliteal, okay, to strip, we have to strip. It is incompetent saphenofemoral, so it will be transmit the high pressure of the deep system to the long or to the short saphenopopliteal. I have to strip excision of this vein. Now for the branch, either pancectomy or what we call avulsion or ligation by multiple incisions. For the incompetent perforator by the duplex, either this excision of the flipectomies of the multiple stab branch varicoses plus to the stripping, the incompetent perforator, it might be ended if they are along the course of the long saphenous. If they are not along the course, I can by individual ligation of these perforators. Any patient coming with varicose veins complaint, he is indicated for treatment. Either even he is presented by disfigurement. He has his right to correct this disfigurement. So indication for treatment either pain, fatigability, heaviness in the limb, recurrent superficial thrombophlebitis, it is a complication known in the varicose vein, external bleeding, varicose vein or bleeding ulcer, and the appearance or disfigurement is an indication. What are I discussed the operative, it is the ligation and stripping or perforator mini incision ligation of the perforator. What are the non-operative? We can, okay, by external compression, as I said before, by elastic stocking or by crepe bandage. So leg elevation and exercise are the main cornerstones for conservative treatment of the varicose veins. The external compression is by triple layer compression or simply by crepe bandage or even by elastic stocking. This should be avoided or wisely used in significant arterial diseases. Significant. If it is combined, we can find a combined venous and arterial patient like in Berger thromboangiitis obliterans. So if the arteries are not heavily affected, so we can use elastic stocking. But if the lower limb is suffering from severe ischemia, it is avoided the elastic stocking. The another contraindication is the cellulitis, inflammation of the skin line in these features. It is cellulitis of the leg. I cannot put a synthetic material to compress and inflame the skin. Pneumatic compression therapy. This is intermittent compression by this apparatus, okay, like shown, 2 to 3 times daily to compress, like a massage or heavily massage to compress the leg to evacuate it from the edema. Sclerotherapy. It is a chemical irritant injected just inside the vein. This idea causes endothelial damage by their action as either osmotic or detergent agent. It destroys the intima. So when the intima is destroyed, so there is a closure of the veins. They are either detergent agent like sodium tetradecyl sulfate, rarely used nowadays. The most used is the polydocanol, what is known as etoxysclerol. Polydocanol is the etoxysclerol. It is the most common use. We can use an osmotic agent like the hypertonic saline or the glycerin. The hypertonic saline could be used to occlude the venous malformations, huge malformation, arteriovenous malformation, the venous part, we can occlude by a hypertonic saline. It is not actually used in sclerotherapy for the easiest of the polydecanol without any side effects, mostly. What is the surgical management? Physical destruction of the vein with its partial or complete removal, like the ligation and stripping of the vein, long saphenous or short saphenous ligation and stripping. Ligation of the long saphenous, we have to ligate as a saphenofemoral. Again, we have to ligate the tributaries before entering the saphenofemoral to avoid recurrence within these tributaries, forming lower abdominal varicosities or iliac or perineal varicosities. We have to ligate each individually. Then we ligate the saphenofemoral and remove the vein, what we call stripping of the vein. The small branched or small tributaries, we have to remove it by phlebectomy or by step incision, small step incision, okay? Then remove it by special needle, what we call crochet needle. We can remove these phlebectomies. Powered phlebectomy, we can by, if there is a huge or there is a clot, superficial thrombophlebosis, so a large incision, and I will remove this huge vein. Again, by open or endoscopic perforator ligation. The perforator I can make open by mini-incisional, then subfacial, superficial ligation of the perforator. I will detect and ligate it either subfacial, below the deep fascia, or above the deep fascia, or by endoscope. If there is an unhealthy lower third of the leg by dermatoliposclerosis and pigmentation, so the skin is very weak, so I have to enter a proximal part in a healthy skin in the upper third of the leg, deep fascia. Then I eliminate by the endoscope where is the perforator, and I will ligate by an incision started away from this unhealthy skin. Surgical treatment may be used to remove clusters like this features, or ambulatory phlebectomy may be performed using the stab avulsion, as I said before. When a larger or lesser saphenous incompetence, ligation and stripping techniques are best done from above downwards to avoid saphenous vein injury, okay, or lymphatic injury. So the patient after surgery will not complain from numbness, burning sensation due to saphenous vein affection. The endoscopic, what I prescribed, is the what we call SAPS, subfacial endoscopic perforator surgery. We perform it, as I said, to avoid the unhealthy skin. The endovenous laser ablation, or what we call the new modalities, okay, ablation of the veins by catheter. This catheter is either a laser or radio frequency catheter. So laser emit a single coherent wavelength of light, which is based upon the concept of selective photothermolysis. So it by induce high temperature, okay, will damage the intima, and then the superficial vein will closed due to injured intimal layer. Either it could be made in the great saphenous vein, small saphenous, or incomplete even, but we have to be away from the saphenofemoral or major perforator to avoid transmission of the therma or temperature, high temperature, to the deep system. Then it will occlude and will patient transform to a deep vein thrombosis. Another modality, what I said, the radio frequency endovenous ablation. It is an endovenous, okay? So the endovenous, it is this apparatus like this, and the probe like that, and the emitting radio frequencies is this apparatus which emitting, okay? We enter by duplex ultrasound to detect the long saphenous, then enter inside by the probe to ablate by the apparatus this vein. This is an example before and after radiofrequency endovenous ablation. If I'm in doubt deep system is healthy or not, so as I said, I will perform a venogram, ascending venogram. If there is any affection in the pelvic or inferior vena cava, it will be detected by the ascending venogram. For example, it might be the venous hypertension not from the valves. It is secondary to pelvic vein, external iliac stenosis, for example, okay, or from inferior vena cava compression. And we have May-Turner syndrome, the May-Turner syndrome is the most known affecting this system. It affects usually the left side due to compression of the iliac artery compressing the iliac vein. So it is transmitted by swelling of the left lower limb, and the lesion is normal. It is in a normal patient, but could be passed unnoticed or manifested by lower limb edema following a chronic venous insufficiency. So this will be managed by a high iliofemoral stenting. With C-arm, I detect the site of this stenosis, and I will open by a stent to maintain it open. This is our lectures in short. What is the chronic venous insufficiency? What are the classifications? We have to study the anatomy well to understand the presentation, clinical manifestation, and how to investigate, and the minimal to approach to this study. Thank you very much for your attention.